Good morning. I'm Dr. Adelaide Hebert from the UTHealth McGovern Medical School in Houston, Texas, in the United States. I'm happy to present for you today a construct on diaper dermatitis. I want to give you an overview of the history of diaper use, recent advances in diaper dermatitis care, therapy, and differential diagnosis of diaper dermatitis. The history of diaper use is a very long one. We know that the Egyptians and Aztecs and Romans all described the use of diapers. I'll talk a little bit about the European swaddling bands and Eskimos, what they did with moss. Here's the original construct of a diaper. Swaddling bands were used with a diaper pin. And here, the early native Indians in the United States put grass under rabbit skin and wrapped their babies, as illustrated. Back in the 1820s, at least in the United States and in Europe, the working class had sufficient funds to actually buy furniture and really wanted to protect their investments, so they started diapering their children in a special way. Early diapers had many components, including linen and cotton flannel. And this illustrates how they held these cloth diapers in place with a diaper pin. Now, the diaper was originally constructed as a small triangular piece of cloth. These were made in mass production as early as 1887. There was a boater invented in 1947 by someone named MARION. She actually made a plastic cover of diapers from a shower curtain so that the diapers wouldn't leak, and she won 4 patents. She couldn't get anyone to hire her, so she went ahead and went business for herself and actually sold her company early on for $1 million. Here she is depicted with her early construct of a diaper and a diaper cover that was plastic. Back in 1961, Procter & Gamble in the United States introduced the construct of disposable diapers, and it really made a big difference in overall diaper dermatitis prevalence. In the United States, there are over 18.6 million units of disposable diapers actually sold every single year. We have a recent journal article that really looks at the art of prevention of diaper dermatitis and the importance of diapering practices, where we have several initiators of diaper dermatitis that I will cover with you today. Most importantly, one must recognize the damage that occurs to the stratum corneum and the epidermis with resultant increase in skin permeability. There is overhydration in the diaper area simply from wearing the occlusive diaper in place. Also, the exposure to both feces and urine, unfortunately, lead to skin breakdown and maceration because of increased moisture. The skin then becomes more susceptible to frictional forces and damage from the diaper itself. And then that injury of the stratum corneum, the epidermis, lead to the diaper dermatitis that we see. What's very important to understand in diaper dermatitis is the impact of skin pH. The fecal ureases actually catalyze the production of ammonia from the urinary urea. This increases the skin's pH, which activates, in turn, fecal proteases and lipases. So we consider these some of the most significant irritants in the whole arena of diaper dermatitis. Now, there is a positive correlation between the number of bowel movements and the amount of diaper dermatitis that we see. Any mother, grandfather, or actively involved father can tell you that this is true. We know that this increases fecal enzyme concentration in the diaper area, and thus more diaper dermatitis results. Now, we know that the urine and fecal enzymes increase skin permeability to irritants. The bile salts, unfortunately, further potentiate fecal enzyme activity, and thus there is an ongoing breakdown in the skin barrier in the diaper region. Here is an example of very severe diaper dermatitis, and we know that just one day of diarrhea or a few bouts of diarrhea can cause this resultant erosion in the diaper area skin. Some recommendations to help manage diaper dermatitis include avoiding the use of diaper wipes that contain alcohol or fragrance. Using a cleanser with a slightly acidic pH can be helpful, and avoid traditional soaps due to the more alkaline pH that they contain. Now, breastfed infants do a little bit better because their stool has a lower pH, which is less irritating to the skin overall. Premature babies, because of the immaturity of the skin, are more prone to diaper dermatitis, as we know it takes weeks to develop a normal skin pH and a full barrier function. There are key elements in the management and prevention of diaper dermatitis. These include giving the skin of the diaper area air, helping restore the barrier, cleansing appropriately, having a dry diaper as often as possible, and of course, education of the parent to change the diapers frequently and take care of the skin appropriately. There is a large differential diagnosis of diaper dermatitis, including candidal diaper dermatitis, seborrheic dermatitis, and other arenas. I'll illustrate these differential clinical pictures for you in slides that follow. Here we have candidal diaper dermatitis with characteristic erythema and a few satellite lesions. Here is another example where it's less red but has more satellite lesions. And irritant diaper dermatitis can appear as such. The skin is red, slightly superficially denuded and scaly. And here is erosive diaper dermatitis, which can certainly occur if the diaper is too tight, left on too long, or if alcohol-containing diaper wipes are applied to this area. Now here we illustrate seborrheic dermatitis both in the face and the diaper area, a very common problem in early childhood. And here we illustrate it on the neck and the diaper area additionally. Here we see an illustration of psoriasis with sharp demarcation of plaques that uniquely affect the diaper area, but can also be seen on the trunk and extremities. This baby also has a sharp demarcation illustrating the clinical picture of psoriasis. This third picture is another baby with sharp margins illustrating psoriasis. Allergic contact dermatitis can certainly occur in the diaper area as a function of baby wipes that contain fragrance or benzalkonium chloride or isothiazoline. Impetigo can also develop because of the occlusion in the diaper area, and that is illustrated for you here. Now, acrodermatitis enteropathica is a more rare form of diaper dermatitis. It can be accompanied with some of the erythema seen on the head and neck region, as I've illustrated in this slide. This baby did have acrodermatitis enteropathica with bright red changes in the diaper region. And I want to challenge you to think about Candida, which can go into the folds, and acrodermatitis enteropathica, which does not. So these can be distinguished clinically, but do need proper evaluations to be sure you have the right diagnosis. And while more rare, kwashiorkor can result when nutritional intake is either inadequate or unavailable, as illustrated in this child who was fed only rice water for several weeks. There is a new therapeutic horizon in diaper dermatitis, and I will have this article published soon in the International Journal of Women's Dermatology. There are 4 main pathophysiologic factors that result in the development of diaper dermatitis, and these include irritation, a defect in the skin barrier, inflammation, and microbial contamination. We have a number of recent articles in the literature that remind us of the importance of the pH in managing diaper dermatitis in patients that are affected with this condition. We also have review articles talking about prevention of diaper dermatitis in infants. There is a scientific rationale for a number of key ingredients within agents that we use to manage diaper dermatitis. These include barrier repair creams such as zinc oxide, dexpanthenol, taurine, and zinc gluconate. We know that there is a new clinical evidence-based paradigm for managing diaper dermatitis, and these include those key agents, zinc oxide, dexpanthenol, taurine, and zinc gluconate, as well as almond oil. These are available in Relizima Baby Care Cream and Relizima Spray and Go. These have been evaluated and shown to have very good protective qualities and erythema-reducing properties when managing patients with diaper dermatitis. The studies included children from 3 to 36 months with lower Fitzpatrick skin types. In conclusion, there are 4 main pathophysiologic mechanisms that we associate with the propagation of diaper dermatitis. These include irritation, a skin barrier defect, inflammation, and microbial contamination. Based on clinical studies, we know that key ingredients can certainly help us manage diaper dermatitis in an effective way. And I thank you today for your time and attention.